So good morning. Let's learn about the various anti-cancer drugs. The first is non-cell cycle specific drugs, which includes alkylating agents, platinum compounds, and anti-tumor antibiotics. The next is cell cycle specific drugs, which can be either S-phase inhibitors or the M-phase inhibitors. The S-phase inhibitors are the antimetabolites, antifolates, pyrimidine analogs, the purine analogs, topoisomerase 1 and 2 inhibitors, histone deacetylase inhibitors, and hydroxyurea. The various M-phase inhibitors includes vinca alkaloids, taxanes, epothelions, eribulin, and extramastin. What are the common side effects of anti-tumor drugs? The first is because of inhibition of the normal cellular proliferation, the bone marrow cells are affected, which is the most common, limiting toxicity, dose limiting toxicity, and the hair follicles affected leading to alopecia, germ cells affected, infertility, GIP cells affected, mucositis and diarrhea, intrachromaffin-like cells. There is because of increased 5-HT levels, the patient is going to land up in nausea and vomiting because of these drugs. And you need to give drugs to prevent the nausea and vomiting because of anti-tumor drugs. So what are the drugs that you give? We'll see. The first is in cases of severe nausea and vomiting, which is commonly seen with cisplatin, you can go for ondansetron, aprepitant, dexamethasone, and olanzapine. If it is moderate nausea and vomiting, you can go, which is again commonly, this is severe is commonly seen with cisplatin, moderate nausea vomiting seen with carboplatin. You can give ondansetron, aprepitant, and dexamethasone. In cases of mild nausea vomiting, which is seen with most drugs, you can give any one of the drugs, but the most preferred is dexamethasone for mild nausea and vomiting. The next is let's learn about the drug of choice in cases of carcinomas. The first is brain tumor. The drug of choice is temozolomide. For head and neck cancer, oral drug is cisplatin and alternate drug is cetuximab. But we mainly prefer cisplatin in cases of head and neck cancer. And along with the regimen, either with the cisplatin or the cetuximab, you have to give 5-fluorouracil. This is the regimen for head and neck cancer. For brain tumor, you have to go for temozolomide, which is a drug of choice. The next is head and neck cancer. The oral drug is cisplatin, alternate drug is cetuximab. The regimen, along with that, you have to give 5-fluorouracil. For esophageal cancer, the drug of choice is cisplatin. Gastric cancer, again, cisplatin. Colorectal cancer, the drug of choice is 5-fluorouracil. We have certain regimens for colorectal cancer, the FOLFOX, FOLFIRI, and the FOLFIRINOX. So, along with the regimen, you have to give oxaliplatin, irinotecan, and folinic acid. Anal cancer, again, 5-fluorouracil is the drug of choice. The regimen is 5-fluorouracil plus mitomycin C is going to be the treatment of choice for anal cancer. The next is urogenital carcinoma for bladder, uterine ovary, testicular, cervix, and the prostate cancer. The drug of choice remains cisplatin, except in cases of prostate cancer. I'm sorry, except in cases of prostate cancer, the drug of choice is goserelin, which is a GnRH agonist. So for urogenital cancer, which includes bladder cancer, uterine cancer, ovarian cancer, testicular cancer, and the cervical cancer, the drug of choice is cisplatin. For prostate cancer, the drug of choice is goserelin, which is a GnRH agonist. The next, this regimen, what you give for urogenital cancer, you have to add gemcitabine and paclitaxel. If there is no response, even after adding gemcitabine and paclitaxel, you can go for nivolumab and pembrolizumab. Nivolumab and pembrolizumab. This nivolumab and pembrolizumab, they are immune checkpoint inhibitors. And the other drugs that can be added to the regimen is bleomycin and etoposide. We'll be seeing about them in the subsequent section. So first is urogenital carcinoma, uterus cancer, bladder cancer, ovarian, testicular, and the cervix cancer. Drug of choice remains cisplatin. And for that, for the regimen for urogenital cancer, add gemcitabine, paclitaxel, bleomycin, etoposide. If there is no response to gemcitabine and paclitaxel, you have to add nivolumab, pembrolizumab, which is immune checkpoint inhibitor. Prostate cancer alone, goserelin, which is a GnRH agonist, is the drug of choice. The next is retinoblastoma. The treatment regimen for retinoblastoma is VEC, which is vincristine, etoposide, and carboplatin. For lung cancer, both the small cell and the non-small cell lung cancer, the regimen is cisplatin plus etoposide. If there is no response, you have to give nivolumab plus pembrolizumab. The next is hepatocellular carcinoma. The drug of choice for HCC is sorafenib. Pancreatic carcinoma, FOLFIRINOX. I already mentioned the FOLFIRINOX regimen in cases of colorectal cancer. FOLFIRINOX is a regimen which is used for pancreatic cancer. Malignant pheochromocytoma, vincristine, cyclophosphamide, and dacarbazine. Renal cell carcinoma, pembrolizumab. The next is osteosarcoma. Osteosarcoma, you have to give MAP regimen plus ifosfamide. MAP is methotrexate, high dose, adriamycin, and the platinum compounds like cisplatin. So osteosarcoma, methotrexate, adriamycin, cisplatin. For lung cancer, small cell lung cancer, which is limited disease, cisplatin plus etoposide. If it's an extensive disease, cisplatin plus etoposide plus pembrolizumab. Let's learn about the various drugs for non-small cell lung cancer. It depends on whether the patient has got mutation or not. If the patient doesn't have any mutation, you have to give chemo, and the chemo includes cisplatin plus etoposide plus ICP inhibitors. What are the various immune checkpoint inhibitors that you can give? Pembrolizumab or atezolizumab, or you can give a double immune checkpoint inhibitors, nivolumab plus ipilimumab. Keynote 189 trial may you have to give chemo. What it says, this trial says you have to give chemo plus pembrolizumab. So this is what is the regimen that you follow if there is no mutation. So for non-small cell lung cancer, if there is no mutation, you have to give chemo. This chemo includes cisplatin plus etoposide plus immune checkpoint inhibitors like pembrolizumab or atezolizumab. If there's a double, you can also give. This is one regimen. You can also give double checkpoint immune checkpoint inhibitors like nivolumab, ipilimumab. Keynote 189 trial says you have to give chemo plus pembrolizumab. If the patient has got EGFR mutation, you can give a first generation tyrosine kinase inhibitors, gefitinib, erlotinib. And if the patient has got T790M mutation, which means the patient will not show any response to gefitinib, erlotinib. If there is resistance to that, you have to go for second generation, which is afatinib and dacomitinib. And this afatinib and dacomitinib, they have increased toxicity. And you can also go for third generation tyrosine kinase inhibitors, and this is mainly used in L858R mutation, osimertinib. Let's learn about the ALK mutation. If the patient has got ALK mutation, you have to give first generation ALK inhibitor, which is crizotinib. L1196 mutation, you have to give a second generation, which is alectinib, brigatinib, which is also used in T790M mutation, ceritinib. If there is resistance to that, you have to go for a third generation one, which is lorlatinib. These are the various ALK inhibitors. The first generation is crizotinib. L116 mutation, go for second generation. Alectinib, brigatinib, which is also used in T790M mutation, ceritinib. Ceritinib, if there is resistance to that, especially when there is G122R, 1202R mutation, third generation ALK inhibitors should be used, which is lorlatinib. For breast cancer, ER positive breast cancer, in cases of premenopausal females, you have to give tamoxifen. For postmenopausal, letrozole. If there is no response to letrozole, go for fulvestrant, elacestrant, which is ESR1 mutation, you have to go for elacestrant. HER2-positive breast cancer, we know trastuzumab is a drug of choice. There is resistance to that, you can go for niratinib, pertuzumab, and lapatinib. In case of triple-negative breast cancer, go for doxorubicin, carboplatin, paclitaxel. As an add-on drug, you can go for pembrolizumab. In cases of BRCA mutation, go for olaparib. So breast cancer, ER positive, premenopausal tamoxifen, postmenopausal letrozole. If there is no response to letrozole, go for fulvestrant and elacestrant. Elacestrant give if there is ESR1 mutation. HER2 positive breast cancer, trastuzumab drug of choice, resistant to that, niratinib, pertuzumab, and lapatinib. Triple negative breast cancer, doxorubicin, carboplatin, paclitaxel. As an add-on drug, you can go for pembrolizumab, and for BRCA mutation, you have to go for olaparib. Very, very, very important breast cancer drugs. The next is hematological malignancy. What you go for leukemias, especially if there is acute leukemias, for ALL, give vincristine, prednisolone, asparaginase, and daunorubicin. So VPAT. So for ALL, what is the regimen that you give? Vincristine, prednisolone, asparaginase, and daunorubicin. For AML, give cytarabine plus idarubicin or daunorubicin. The patient has got FLT3 mutation, midostaurin. Midostaurin because it is an FLT3 kinase inhibitor. So for AML, give cytarabine plus idarubicin or daunorubicin. If the patient has got FLT3 mutation, go for midostaurin because it is an FLT3 kinase inhibitor. The lymphomas, for Hodgkin's lymphomas, you can give adriamycin, bleomycin, vinblastine, and dacarbazine. A, B, V, D, adriamycin, bleomycin, vinblastine, dacarbazine. No response to that. Nivolumab, pembrolizumab. The next is chronic malignancies, which includes hematological malignancies, which is CLL. For CLL, you give fludarabine, cyclophosphamide, and rituximab. fludarabine, cyclophosphamide, and the rituximab for CLL. The next is CML. For CML, the drug of choice is BCR aryl tyrosine kinase inhibitors. The first generation imatinib is the drug of choice for CML and GIST. Imatinib is the drug of choice for CML and GIST. This is very, very, very important. If there is no response to imatinib, you can go for second generation tyrosine kinase inhibitors, which is dasatinib, nilotinib, and bosutinib. If there is no response to that and the patient has got 351 mutation, go for third generation, which is ponatinib. If there is no response to ponatinib, you can give asciminib or omacetazine. This omacetazine is actually going to inhibit BCR-ABL fusion protein, or it also inhibits TNF alpha. This asciminib it's actually an allosteric inhibitor. It's gonna act at the allosteric site of the enzyme tyrosine kinase, whereas the other drugs, the first generation, which is imatinib, the second generation dasatinib, nilotinib, bosutinib, and the third generation ponatinib, they're gonna act on the enzymatic site of tyrosine kinase enzyme. The next is non-Hodgkin's lymphoma. For low-grade tumor, you have to give FCR, which is fludarabine cyclophosphamide rituximab. In case of high-grade tumor for non-Hodgkin's lymphoma, the famous R-CHOP regimen. R is stands for rituximab, cyclophosphamide, hydroxydonorubicin, oncovin, and prednisolone. For the other tumors, for example, hairy cell leukemia, cladribine, polycythemia vera, essential thrombocythemia, sickle cell disease, you have to give hydroxyurea. We all know hydroxyurea is used in sickle cell disease, but hydroxyurea is also used in polycythemia vera and essential thrombocythemia. For multiple myeloma, the famous bortezomib, lenalidomide, and dexamethasone. The next is, what are the various side effects of anti-cancer drugs? First is vincristine is a neurotoxic. It is neurotoxic and causes SIDAH like symptoms. Citarabine is cerebellar toxic. Citarabine is cerebellar toxic. Vincristine is neurotoxic. Cisplatin causes, I already mentioned, it causes maximum nausea, vomiting, and also it's nephrotoxic. In order to prevent that, you'll have to give one to flush the patient 1 to 2 liters of normal saline, which causes chlorodiuresis, and this chlorodiuresis is going to it's going to inactivate the cisplatin. In order to treat the nephrotoxicity associated with cisplatin, you can also use mannitol and amifostine. Next is bleomycin. Very famous question. Bleomycin causes flagellate dermatitis, and foot syndrome is caused by capecitabine greater than 5-fluorouracil. To prevent this hand foot syndrome, you have to go for B6 supplementation. The next is irinotecan causes diarrhea, and the treatment of irinotecan induced diarrhea, you have to use loperamide. Hemorrhagic cystitis, we all know it's caused by cyclophosphamide, but hemorrhagic cystitis is caused by ifosfamide greater than cyclophosphamide, and to prevent that, you have to give mesna. Pulmonary fibrosis caused by bleomycin busulfan, very important question. Cardiotoxicity is caused by doxorubicin, daunorubicin, and trastuzumab. To prevent the cardiotoxicity because of these drugs like doxorubicin, daunorubicin, trastuzumab, you have to give dextrazoxane. The next is hepatotoxicity. Hepatotoxicity because of 6-mercaptopurine and 6-TG. Methotrexate is also hepatotoxic, which this methotrexate can also cause cirrhosis, especially in rheumatoid arthritis and psoriatic arthritis patients. So hepatotoxicity is mainly because of 6-mercaptopurine, and it's also because of methotrexate. Methotrexate can cause cirrhosis in rheumatoid arthritis patients, psoriatic arthritis patients. Bone marrow suppression is caused by pemetrexed and methotrexate. To prevent the bone marrow toxicity suppression because of pemetrexed or greater than methotrexate, you have to give folic acid, which is glucovorin, supplementation along with vitamin B12 induction for pemetrexed. The next is non-cell cycle specific drugs. So, what are the various non-cell cycle specific drugs? First is alkylating agents. Uh, here, which is important, is see this in alkylating agents pain, this alkyl group is devoid of hydrogen atoms. So this alkylizing agent binds with the hydrogen atom on guanine, which is the N7 position of guanine. So because of which there is guanine mispairing with thymidine, and abnormal DNA formation is what you should take. Alkylating agents causes abnormal DNA formation. Abnormal DNA passes by check gates and causes a result in cell death, cytotoxic effect. Sometimes what happens is the check gates are not functional, and these anti-cancer drugs, they themselves cause proliferation of the cells and lead to secondary cancers, AML, most commonly seen with platinum compounds and alkylating agents. So let's learn about cyclophosphamide. This cyclophosphamide, it belongs to the group of nitrogen mustards. Cyclophosphamide is a prodrug, and after we take cyclophosphamide in the body, it gets converted into the active form, which is 4-hydroxycyclophosphamide. What are the uses of cyclophosphamide? In female, it's used in case of breast and ovarian cancer. In kids, it's used in the treatment of neuroblastoma, Wilms tumor, ALN, and non-Hodgkin's lymphoma. It gets metabolized in the liver, and what happens is It gets converted into chloroacetaldehyde, which is neurotoxic and causes GTCS, generalized tonic clonic seizures, and ataxia. It also gets converted into inactive compounds in the liver and is excreted, but some of it is converted into chloroacetaldehyde, which is neurotoxic. And aldoposamide is also toxic. And acrolein, aldoposamide may gets converted into acrolein, which causes hemorrhagic cystitis. And to prevent that, we give mesna. And this phosphodamide is mustard. This is also a cytotoxic metabolite of cyclophosphamide. This what is the drug of choice where cyclophosphamide is used? Is it's drug of choice for beginners granulomatosis, steroid-dependent nephrotic syndrome. Cyclophosphamide is a drug of choice. The next is ifosfamide. So this ifosfamide, it is same pharmacokinetic property. It is metabolized by liver as that of cyclophosphamide. What are the various uses of ifosfamide? It is used in osteosarcoma, testicular carcinoma, and side effects are more with ifosfamide when compared to cyclophosphamide. It causes hemorrhagic cystitis and neurotoxicity. And let's learn about the next drug, which is meclorethamin. So this meclorethamin is used on Hodgkin's disease, and side effect is causes desiccation. To prevent that, you have to go for rapid IV infusion. The next is melphalan. This melphalan is used in multiple myeloma. Chlorambucil is used in chronic lymphocytic leukemia. The next is carmestin, lomestin, and simestin, which is used in brain tumor because they have got a good blood-brain barrier penetration. The side effects, they cause neutropenia. Carmestin, lomestin, and the simestin. The next is streptozotocin. This streptozotocin, you all should remember, is the drug of choice of pancreatic beta islet cell tumor. And let's learn about the alkylating agents which acts by methylation, which is dacarbazine and procarbazine, which is used in Hodgkin's disease. Side effects, they cause MAO inhibition, disulfiram-like reaction, which is the anti-tumor drug that causes disulfiram-like reaction, which is, dacarbazine, procarbazine, alkylating agents which acts by methylation. Temozolomide is a drug of choice for brain tumor, and busulfan is used in chronic myeloid leukemia, but we all know busulfan causes pulmonary fibrosis. The next is platinum compounds, very, very, very important. The mechanism of action. The first is the platinum compounds. What are the various bivalent platinum compounds? Cisplatin and carboplatin. Whereas the quadrivalent platinum compounds includes oxaliplatin. So bivalent is cisplatin and carboplatin, whereas the quadrivalent is oxaliplatin. Side effects, they cause nephrotoxicity. These platinum compounds, they cause nephrotoxicity as a side effect. In order to prevent that, you can give 1 to 2 liters of normal saline, causes chloride diuresis. That's going to inactivate cisplatin. You can also go for mannitol and amifostine. They also cause ototoxicity as a side effect. Maximum nausea vomiting is because of platinum compounds and peripheral neuropathy. The next is cisplatin is a drug of choice in cases of head and neck cancer, lung cancer, esophageal cancer, gastric cancer, and urogenital cancer. Head and neck, lung, esophageal, gastric, urogenital cancer. Cisplatin is a drug of choice. And next is oxaliplatin. Oxaliplatin is used in colorectal cancer, pancreatic cancer. The side effect is peripheral neuropathy. Carboplatin is less toxic compared to cisplatin, and its use is similar to cisplatin, but just that is less toxic. Side effects, it causes bone marrow suppression. The next is anti-tumor antibiotics. Anthracyclines, very, very important. They block the topoisomerase 2 and they block the A space, because of which they block the A space of the cell cycle, and they also block the free radicals, and you also block the G2 phase. And the next is it needs iron for radical generation. And the next is the side effect is it is cardiotoxic. In order to prevent the side effect, you can give dexrazoxane. So what you have to remember from anthracycline is that just remember it is going to block topoisomerase 2 inhibitors, blocks the S phase of cell cycle, and it also blocks the G2 phase of the cell cycle, and it needs iron for radical generation. Side effects cardiotoxic, prevention dexrazoxane. And the next is doxorubicin atromycin, which is used in cases of osteosarcoma, Hodgkin's lymphoma. Idarubicin, daunorubicin plus citarabine is used in AML. And side effect, we all know cardiotoxicity, maximum with doxorubicin, but daunorubicin also causes maximum cardiotoxicities with doxo and dono, and red color urine is also with doxo and dono. Epirubicin is used in breast cancer, valrubicin is used in bladder cancer, metasatrone is used in multiple sclerosis and myelogenic leukemia like AML. The next is bleomycin. Bleomycin has got mechanism of action similar to anthracycline. It is used in Hodgkin's disease and testicular cancer. Side effects: the deficiency of bleomycin hydrolase, which is responsible for bleomycin metabolism. If it is deficient, it will give rise to toxicity. Bleomycin toxicity. The lung may it causes pulmonary fibrosis because of type 2 pneumocystis damage. Skin it causes flagellate dermatitis. So bleomycin is used in Hodgkin's disease, testicular cancer. If there is bleomycin hydroxylase deficiency, it results in bleomycin toxicity. Lung may causes pulmonary fibrosis, flagellate dermatitis, bleomycin. That's it. The next is actinomyces D, dactinomycin. It binds to DNA, inhibits RNA polymerase, used in corneocarcinoma, Wilms tumor. It causes radiation recall syndrome. And this radiation recall syndrome is seen in dactinomycin, doxorubicin, and tororubicin. Mitomycin C is going to inhibit topoisomerase 2, similar as alkylating agent. Ivy root and ocular may it prevents corneal scarring. Mitomycin C. It's mainly mitomycin C is used in the treatment in various surgeries, to prevent corneal scarring, and it's used in topical route to prevent synechial formation of stenosis in laryngotracheal and the nasal surgeries. And the side effect is it causes hemolytic uremic syndrome. Hemolytic uremic syndrome.